All right, let's get started. So we are entering module 3. Okay, so we're entering material that's going to be covered on exam 3. We're moving into the product collection process. So we're going to talk about donors today. If any of you guys have donated blood, you've gone through that questionnaire. We're kind of going to go behind the reasoning for those questions. We're also going to talk about, and then once that unit is collected, what testing must be done on that unit, and then how each product is derived. So in the old days, they used to just, you could donate a unit of blood. It was whole blood. That was your red cells, your platelets, your white cells, and your plasma. And then that whole unit would be transfused. Now we break that whole blood up into separate components depending on what your patient requires. Maybe if they are anemic with a low hemoglobin and hematocrit and they only need oxygen carrying capabilities, then packed red cells would be the appropriate product of choice for them. Versus maybe if they have a coagulation disorder where they're lacking a specific factor, we could give them fresh frozen plasma. There's a huge concern with transfusing whole blood. You could give your patient, we're going to talk about this in a future lecture, circulatory overload. All right, so while they might need oxygen carrying capabilities, all that excess plasma could overload their circulation. All right, so they don't need all that excess. So the development of all these products has really enhanced patient outcomes. Okay, so it's better for the patient. So that's what this section is gonna move into, concentrating on our donors and the development of those products, testing, including what blood bank test, as well as infectious disease testing, okay? All right, so just some blood donor stats for you. Only about 5% of the US population actually donates blood. And it is research that every 2 seconds, somebody in the United States needs a blood donation, all right? So this is why all of your donor centers are always searching for donors, okay? And if you are O negative, they will call you every 8 weeks, right? And as a reminder, begging you to come in. And oftentimes, even these donor centers offer incentives. It might not be cash, but it might be a free t-shirt or some type of little trinket to get you to come in, okay? Some stats, it's about 40,000 units of blood that are needed, and it's actually the white population that donates more frequently than our African-American population. So there are some, I said some donor centers won't pay you. There are some that will pay you if any of you guys are in desperate need of money as a poor student. There are some donor students or centers that will pay you for your plasma. I think it's like $80 per unit. So yeah. So if you're doing a plasma donation, it's through the apheresis technique that we'll talk about. And so usually it's going to require, you can do 1 arm or 2 arms. If it's a continuous flow, it'll require both arms. So they're going to pull your blood out through 1 arm. It's going to go into an instrument. It's going to separate your red cells from your plasma. They're going to keep the plasma, but they're going to give you your red cells back. So blood comes out 1 arm, goes back in the other arm. That's a continuous open system.
What effect does that have on you?
You can donate plasma every 4 weeks. So just make sure you stay hydrated so you can, rebuild your fluids. $80 every, yeah. So if you have good veins and are able to do it, there's one, I can't remember the name of it, but it's down on Chenal here in Little Rock. Yes, ma'am.
Doesn't it make you really cold because they put backing?
It does make you cold, and there's also, and we're going to talk about a side effect. The anticoagulant that they use during the washing procedure has citrate in it, and so you guys know that citrate chelates calcium. And so if you were if your calcium levels were to drop, you could have your lips might turn blue and start tingling. And so the way they do that, they just give you some Tums and to kind of help with that. So that's a known side effect. But other than that, you shouldn't have any side effects because you're getting your red cells back, so you're not going to go anemic or anything like that. So the only thing is they want you to drink plenty of fluids after. All right, so types of blood collection. We will talk a lot about allogenic blood collection, transfusions. That is when the unit is coming from a different donor. Another word for that would be homologous, meaning that it's coming from the same species, the same type of person. And this is why ABO compatibility is so important. Okay, it's coming from an allogenic donor, somebody other than yourself, but we need to make sure that it is compatible. All right. I mean, again, usually this donation is going to be voluntary, such as the American Red Cross, depending on what donor center is in your area. We used to have American Red Cross here in Little Rock. They're not as prominent anymore now. Arkansas Blood Institute is real big right now. Oklahoma Blood Institute, which is Arkansas Oklahoma is the parent institution of the Arkansas Blood Institute. And so most of those donor centers are on a volunteer basis. Again, plasma, they will usually pay for plasma apheresis, not Arkansas Blood Institute, they won't. That's voluntary. And then we have directed. Directed is if you have a family member that is scheduled for surgery and you are a compatible ABO, you can go and donate, and your unit will only be for that specific person. All right, so if your brother or sister is going for surgery, your mom or dad, and you want to donate blood for them, you have to have a physician's order. You can go to your donor center and they will tag that unit that you donate for that specific patient. That is a directed donation, okay? Versus an autologous donation. An autologous donation is a pre-planned donation where you donate your own blood, and this usually occurs probably about 2 to 4 weeks prior. Maybe you're scheduled for surgery, you're nervous about receiving a random donor unit if needed, you can go and donate for yourself. And it is specifically tagged for you. It will never ever be entered into the random donor pool because it has its own, it's a little more lenient on the infectious disease testing because it's your blood. So if you are, have a previous hepatitis C infection, all right, and it's for you, that unit will never go back into the random donor pool. So it can never go to anybody else, all right? That's one thing about the autologous units. And we're gonna talk about all the requirements for the autologous units as well.
That works for Jehovah's Witness people?
No. So Jehovah's Witnesses have a very strict religious belief. They will not accept blood from anybody else, and they cannot even take it. They have the belief is once the blood has been exposed to air or out of a closed system, they cannot take it. They refuse it. It's against their religious beliefs. However, when I worked here at UAMS and Blood Bank, they can, and we did cell saver, which is a auto cell salvage. So if they lost a lot of blood during the surgery, the surgeon could have a suction. It can go into a instrument that spun it down, washed the red cells, and then it gave it back to the patient. If that was maintained in a closed circuit system, Jehovah's Witness could take the blood that way. So we had to hook our system up to anesthesiology. So it went straight to the bag hanging on the pole and then straight into the patient. So it never, the blood was never like closed off. Does that make sense? It went straight from the patient, washed right back into the patient. Okay. And they will not take anybody else's for sure. It's against their belief. Their belief is they would rather die. So, and if you guys know Jehovah's Witnesses, you can ask them about it. We will talk about the auto cell salvage. That is one thing that Jehovah's Witnesses can do. They will allow that. There's another one that is recently the newest blood collection process on the scene, and it is cytopheresis. Also, you might hear termed apheresis. This is when you are collecting a specific product, like we mentioned, the plasmapheresis. Okay, that is they're keeping plasma, giving your red cells and platelets back to you. All right, you can do this for platelets. We'll talk about platelet pheresis. We'll talk about stem cell. They can do this to harvest stem cells. They can give you an injection of growth hormones, and it will stimulate your stem cells, and then they can pull them out. They can harvest them through the apheresis process. We'll talk about that. platelets, plasma, and red cells. All right, so you can have a red cell apheresis as well. And granulocytes. If any of you guys are ever in blood bank and you do a Buffy coat transfusion, that is your granulocytes. All right, and so you can harvest them as well through the apheresis technique. All right, so let's talk about the process of blood collection. Donors are always in need, so I encourage you all to do your civic duty, donate blood, save lives. All right. And there are some requirements, of course, that we're going to talk about: your hemoglobin, hematocrit, your weight, your temperature, your pulse, your blood pressure. All of that is, if any of you guys have donated, you know you have to go through that every time. And again, most donor centers will offer some type of incentive to get donors in. They even have online process now where you can make an appointment and say, hey, I'm going to come on this day at 4 p.m. when I get off work. You can complete the donor questionnaire online now. So when you go there, all you have to do is give them your vein. Okay. And like I mentioned, so the process involved in donating, the registration, you can actually do that. Most donor centers have that online now, where you can enter all your information. Just make sure if you do it online that when you go to the donor facility that you take your ID with you. They will make sure that you are who you say you are, okay? And then you will have to do a physical exam. They're going to weigh you. They're going to take your temperature. They're going to measure your hemoglobin. More than likely, they'll probably do hemoglobin, maybe a spun hematocrit, depending on what their SOP is. Their blood pressure and your pulse, okay? And you'll go through a health history interview, and this is just a donor questionnaire. Some of the questions are very, what's the right word? Invasive, yes, and it's very personal. They're going to ask you about sexual activity. They're going to ask you how often you drink. Have you been involved in any IV drug use? So it can get very personal, all right? Just be prepared for that. And they're also going to give you some educational material. We want you to be aware of adverse effects from donating. If you guys, I don't think would have an effect, but for the regular person walking in, they need to know, you know, the needle is going to be fairly large, the 16 gauge needle. And so if you have a fear of needle, that could cause some vasovagal reactions, you know, lightheadedness, dizziness, maybe a little nausea or anything like that. Okay, so that's the most common side effect from donating blood. And then also the risk for HIV and all of that, because one thing that is going to happen is when you donate blood, your blood is going to be tested for infectious disease, right? Because we don't want to pass that on to the recipient. Okay, that's a potential adverse reaction for the recipient to get HIV from a transfusion when it's trying to save their life. So in the event you donate blood and you test positive for HIV, hepatitis C, hepatitis B, there's Zika now has been added to the panel. All right, so if you test positive for any of those, it is the donor facility's responsibility to notify you and say that, hey, you tested positive for hepatitis C, you are no longer eligible to be a blood donor, okay? So if you test positive for HIV, test positive for hepatitis C, that's a permanent deferral. And we're going to talk about deferrals too, okay? So we want the donor to be aware of that they might be notified of their infectious disease testing results. And then the collection process, and then we want to make sure our donors, we take care of them after the process, all right? If they're feeling lightheadedness after the donation, we want them to sit there for a while, give them some fluids, make sure they eat something. Most donor centers will have like an oatmeal cream pie, some cookies, something for you to get your energy back up, okay? And then we're going to talk about the donor unit processing. What happens after that donation? If any of you guys have donated, you've probably gone through this process, but maybe you don't know what happens to that unit after you donate, okay? Registration. So when you go to the donor facility, you fill out your all of your information, your name, your date of birth, your social security number, your gender and your age, all of that. If you've had any previous deferrals, why, all that's considered a permanent record. So the donor facility will keep that forever. And oftentimes if you've donated, they'll even send you a donation card in the mail. It'll have your blood type on it. Mine had a place on the back where you could record all of your donations. You could write the date, how much they took, and everything like that. So usually it has a place for you to record donations. They'll keep that too, but then you can keep a personal record for it as well. Age, I have a disclaimer. You must be at least 16 years of age. However, that might vary from state to state. So if your state considers 16 to still be a minor, you do have to have parental consent to donate. Okay, so you might see the age requirement listed as 17. Okay, so usually it's 16 or 17. If you do a 16, you might have to have parental consent in order for that minor to donate. Okay, so just be aware if you read your textbook, it does say 16, but there is a disclaimer in there that says parental consent might be needed. All right. And on gender, so you guys are all probably aware of the gender now. Now you can self-identify. You can, you know, rather than male or female, you can be, I can't remember the right language, but now you can self-identify, all right? Transgender, I guess. That's on the form now. They're also going to ask for your race, and the only reason they ask for your race is because some ethnicities are known to have a unique phenotype. So if you are in the African American population, you're more likely to be Duffy A negative, Duffy B negative. They might, if you are, they might include you in a special donation pool. And so if you are O negative or you have a unique phenotype, they will harass you every 8 weeks because they want your blood. All right. So that's the only reason they ask for your race, because you're more likely to fit a unique phenotype needed for antigen negative blood. Okay. CMV status is not so much a concern anymore. Studies have been done, and that's your cytomegalovirus. That comes into play when we're doing immunocompromised patients, if they need a transfusion, such as our pediatric population, babies. It used to be required that CMV tested on the units, so we want to give them CMV negative units. However, now with the incorporation of leukoreduced, meaning that we filter our units through a very small filter and the white cells get trapped in that filter, it eliminates the risk of CMV. So don't be surprised when we start talking about neonatal transfusions. I'm going to tell you that it has to be CMV negative for neonates. However, if your facility does leukoreduced, that has replaced the need for CMV negative. Okay, so don't be surprised if some facilities don't honor that CMV negative requirement. All right. And we'll talk more about that when we get into special requirements for transfusion special populations. All right, so all of that physical examination, if for any reason, whether it be a question on the questionnaire that identifies your donor as being living a risky lifestyle, okay, maybe they're acting funny, kind of inebriated, all right, so that is a temporary deferral. We don't want them to donate when they're intoxicated, all right. Maybe they have track marks on their arms, okay, that indicates the use of IV drugs, okay, that's a permanent deferral. So not only do you do a physical examination, but you do an overall general appearance evaluation as well, all right. Does your patient seem kind of disoriented? Do they seem very confused? Probably don't want them to donate, all right? And that's just to protect our recipients, because they do lead a life that puts them at risk for infectious disease, all right? So we don't want to put our recipients at risk of getting an infectious disease from the transfusion, okay? So you want to be careful when you defer a donor. If you guys are ever involved on the donor process, when you defer a donor, especially if it's just a temporary donor, maybe they are intoxicated. You want to be careful when you tell them, hey, you seem a little disoriented today. I'm going to defer you for today. Come back, in 2 to 3 weeks. Right? That's a temporary deferral. Versus maybe if they do have marks on the arm, tell them, you don't want to get too personal. You don't want to ask them what the marks are from, but tell them the risk of IV drug use is very harmful for our recipients, and they are not a likely candidate for a donor. So you have to be careful. We don't want to lose them as a donor, because our donor pool is already so small and we're in high demand. So when you defer somebody, you want to kind of be in a nice way about it. Encourage them, if it's not, unless they have track marks on their arm, but encourage them to come back and try again. Right? Maybe their pulse is greater than 100 beats a minute. Okay, that's a temporary deferral. Tell them to come back maybe next week or something. You never know. Maybe they were driving down the road and they were almost in an accident, so they're nervous. And then so their pulse is very rapid at that time. So tell them to come back another day. All right. And then each donor facility has a medical director, so you could always consult with the medical director and get their opinion. All right, so weight. There is a weight requirement to donate blood. You have to weigh at least 110 pounds. Now, your textbook says a weight less than 110 pounds does not defer you. However, our units have an appropriate amount of anticoagulant already in the unit. In the event that you are less than 110 pounds, we are not going to take the 525 standard mils off of you because you're low weight. You don't have that much blood in your circulation, right? So we can take a lower amount of blood from you, all right? Most facilities, if you're under 110 pounds, they will defer you because they don't want to go through the process of calculating how much anticoagulant needs to be taken off. They might tell you to gain some weight and then come back. So, but depending on what the facility's SOP is, all right? So if you're less than 110 pounds and you're scheduled for surgery maybe in 4 weeks, and you want to do an autologous donation, then they could calculate the amount of anticoagulant that needs to be pulled off. Does that make sense? So donors weighing a minimum of 110 pounds can tolerate that maximum 525 mils of blood being taken off. So a typical donation is usually going to take about approximately 450 mils. And so you usually have about plus or minus 45 to 50 mils, all right? So to determine how much allowable amount of blood, if your patient is less than 110 pounds, you take your donor's weight times 450 because that's the standard amount of blood, right, in the unit, and then divided by 110, and that'll get you the allowable amount of blood that can be drawn off of your lower than 110 pounds. So here's an example. So if you have a donor that weighs 90 pounds, you could take 90 pounds times 450 divided by 110. So we would only want to take off 368 mils from this patient, okay, versus the standard 450. And you have to account the amount of blood. We're drawing probably 5 tubes of blood for infectious disease testing as well. So you have to include that in the total amount of blood that we draw off that patient, okay? So when you draw less blood, there is a calculated amount of anticoagulant in your unit, all right? So if any of you guys have donated before, this is probably what your unit looks like. It's a bag, it's a closed system. It might even have a few more ports on it. It might even have some more bags attached to it. But this would be like what we call the parent bag, all right? And so the anticoagulant, CPDA, CPDA1, all the anticoagulants that we're going to talk about, they're already in this bag. And it's 63 mils of anticoagulant in this bag to allow for collection of 525 mils, all right? So if you take off lower amount of blood, you have to adjust the amount of anticoagulant in this bag, okay? So how do we know how much anticoagulant that needs to be adjusted? So if less blood is drawn, it takes 14 mils of anticoagulant per 100 mils of blood, all right? So you can take the allowable amount of blood. So in our previous example, 368 mils, all right? So we could take the allowable amount of blood divided by 100 times 14 because you have 14 mils of anticoagulant per 100 mils of blood in that unit, okay? So let's say you have an underweight patient and we're only going to draw 250 mils of blood, and you did it divided by 100 times 14. 35 mils of anticoagulant is needed. How much anticoagulant is in that bag? 63 mils, right? So if we only need 35, you can pull off some anticoagulant from that bag. So you could take the 63 mils minus the 35. We need to pull off 28 mils of anticoagulant out of that bag, All right, that would give us the appropriate 35 mils. Does that make sense to everybody? How often this is done, I think most donor facilities, if you're under 110 pounds, they're probably going to defer you. All right, so how often you'll see this? Probably not very often. All right, so some physical examination, your temperature. We don't want our donors to have a fever. Fever often indicates some type of infection. So you ask them, one of the questions on the questionnaire that we're going to talk about is, how are you feeling today? What's your overall feeling? If they say, oh, you know, I'm feeling kind of feverish, chills or something, you're like, you could potentially have some type of virus or cold. You know, so we're going to defer you. That's a temporary deferral. Come back when you don't have a fever. All right, so 99.5 degrees Fahrenheit. If you have a temperature greater than that, that's a temporary deferral. Pulse between 50 and 100. All right, so if you have a donor that has a rapid heartbeat at that time, tell them that we don't want to take blood, right? Rapid heart rate, maybe they have some cardiovascular disorder, something. We don't want to worsen that condition, okay? And maybe they could have a reaction during the donation process. So that's a temporary deferral. Come back when your heart rate is not so fast. And then blood pressure, your systolic pressure must be 90 to 180 millimeters of mercury, and then your diastolic must be 50 to 100. So for those patients that have high blood pressure, probably want to maybe they're on blood pressure medications. There are some medications that are deferral as well, but blood pressure medication is usually an acceptable medication. So if you have a patient that has high blood pressure, that's a deferral as well, all right? Because that could indicate, again, cardiovascular disease. We don't want to take blood from those patients, all right? Just because they're already in an anxious state, if you will. So going through the donation process could heighten that or cause more problems for them. All right, hemoglobin and hematocrit. For females, the minimum hemoglobin has to be 12.5 grams per deciliter. The hematocrit has to be greater than 38%, right? For males, the hemoglobin is just a little bit higher, 13 grams per deciliter, and your hematocrit is greater than 39%. However, if you are donating for an autologous donation, meaning that you're donating for yourself, for that unit to be transfused to you at a future date, it has a lower threshold. You can have a hematocrit of 33%. And again, on that physical examination, you want to look, make sure there's no skin lesions, no needle marks, okay? So I took this chart from your textbook. It kind of just outlines all of the physical examination requirements. Appearance, again, you want your donor to be appearing to be in good health, no fever, no disorientation, no visible needle marks on the arms, and then your hemoglobin and hematocrit. Most places are going to do a hemoglobin determination. They'll do the copper sulfate. I don't know if any of you guys have ever donated. They usually do like a finger stick. They'll take a drop of blood and drop it in the copper sulfate to see if it falls, to see if your hemoglobin is high enough. Some facilities might do a spun hematocrit, all right, to determine the hematocrit to see if your hematocrit is high enough to donate. One reason for the hematocrit is if you're already on the anemic side for females with a hemoglobin less than 12.5, we don't want to take 525 mils off of you, right? You're already anemic, you need your blood, right? So you need to keep it, all right? So that's to protect the donor, right? And then blood pressure, temperature, pulse, weight, and age. Right, so your donor questionnaire, right? The questions are designed to offer protection both for the donor and the recipient, okay? And you can donate whole blood unit every 8 weeks. You can do, I think it's plasmapheresis every 4 weeks. This says 48 hours after apheresis, but it doesn't say what type of apheresis. Maybe after a platelet apheresis, you could do 48 hours. All right, again, the age requirement, you must be 16 to 17 years old. If you're 16, you might have to have parental consent. That's the disclaimer with the age. All right, so here's your donor questionnaire. And if any of you guys have ever donated, you guys have gone through this process. The very first question, how are you feeling today? Are you feeling well? Are you currently taking any antibiotics? That question, if you are currently taking antibiotics, means that you have some type of bacterial infection, all right? We don't want you to donate blood that day, all right? We don't want to potentially put our recipients at risk, okay? And then also you need your blood too, right? I mean, because you're fighting an infection, we don't want to take your blood and compromise your immune system as well, all right? And then it asks if you have taken any medications on the medication deferral list. We're going to look at that deferral list. All right, we're going to go over some of the medications. And with those medications, it's not necessarily the side effects of the drugs themselves. It's more of the condition they're treating, all right? There are some that we're going to go over that do have a known side effect. Some of them are known to cause birth defects. So we wouldn't want to expose our pregnant recipients to those side effects, all right? Because if a patient receives that plasma, then that drug is going to be in that plasma, all right? Question number 6 says, have you taken aspirin or any other drug containing aspirin within the last 48 hours? The reason for this question is it's concerning the use of platelets, all right? You guys remember what aspirin has effect on our platelets. It prevents the function of platelets, right? So if your patient has been taking aspirin, we don't want to use that donation for platelets, all right? If your patient says they're on aspirin and they want to do like a platelet apheresis donation, we need to tell them they need to stop taking aspirin 2 days before their donation, all right? And again, if they have donated blood, platelets, or plasma within the past 8 weeks, we want to make sure that they have that 8-week window. Vaccinations or shots, we're going to go over some specific vaccinations, and depending on what type of vaccination determines the length of deferral. Contact with someone who was vaccinated for smallpox in the last 8 weeks. And then you get to this section in the past 12 months. Have you had a blood transfusion? Have you had an organ transplant? Have you had a bone or skin graft? Have you come into contact with someone else's blood? This is for the healthcare workers. Maybe they had a needle stick exposure. Maybe they had a splash in their eye. That would defer them for 12 months, okay? Just to we have a window that we can detect infectious disease. So we want to allow that time that our testing can detect that infectious disease, okay? And it says, sexual contact with anyone who's had HIV or AIDS, or have you yourself had a positive test for HIV? Sexual contact with a prostitute or anyone else who takes money or drugs for payment of sex. Sexual contact with anyone who has ever used needles to take drugs or steroids. So see, when I say these questions are very personal, all right? Very, some might consider them intimidating. Male donors have had sexual contact with other males. On the other side of that, female donors had sexual contact with a male who had sexual contact with another male in the past 12 months. These are all lifestyle questions, all right? What are you engaging in? If you're engaging in these activities, it puts you at a higher risk for infectious disease, okay? That's the purpose of these questions. These questions protect the recipient, all right? This reduces the risk of transmitting infectious diseases to our recipients, okay? Had sexual contact with the person who has hepatitis, live with the person who has hepatitis. Have you had a tattoo or body piercing? If you have had a tattoo or body piercing within the last 12 months, that is a 1-year deferral, all right? So it's 1-year deferral from the date of that piercing or tattoo, right? So if 6 months ago you had a tattoo and you want to donate now, you can't donate for 6 more months. Treated for syphilis or gonorrhea, right? So it's not necessarily that syphilis or gonorrhea can be transmitted through the transfusion, but if you have syphilis or gonorrhea, what does that mean? It means you are sexually active, you are engaged in that lifestyle that puts you at a higher risk of other infectious diseases, okay? Been in juvenile detention, lockup, jail, or prison for more than 72 consecutive hours. That's a 1-year deferral as well. In the past 3 years, have you been outside of the United States or Canada? This is to prevent transmission of bloodborne pathogens such as Chagas disease, babesiosis, trypanosoma. All right, those are all the ones that we're concerned about that can be transmitted. Malaria through blood. All right. And then from 1980 to 1996, did you spend time that adds up to 3 months or more in the UK? Does anybody know what that might be referring to? Yes, Creutzfeldt-Jakob, mad cow disease. All right, so if you traveled that area in this time frame, or if you've ever had pituitary gland injections or derived products from pituitary glands, that puts you at a higher risk for mad cow disease, Creutzfeldt-Jakob. Have you ever, or female donors, have you been pregnant or are you pregnant now? Pregnant females are not advised to donate. They can donate 6 weeks post-delivery, all right? Had a positive test for HIV virus, used needles to take drugs, steroids, or anything not prescribed by your doctor, received money, drugs, or other payment for sex, had malaria, had Chagas, had babesiosis, received a dura mater graft. Again, that's referring to the likelihood for mad cow disease. Had any type of cancer, including leukemia, problems with heart or lungs, bleeding conditions such as a blood disorder, and do any of your relatives have Creutzfeldt-Jakob disease? Okay. So any type of cancer, including leukemia, any type of problems with your heart or lung, any type of bleeding disorders, those questions are to protect the donor, all right? If you have any type of cardiovascular disease, lung disease, we don't want to take blood from you, all right? Going through the donor process could cause you more problems. It's not necessarily that your blood is not good for the recipient, it just puts you at a risk going through the donation process, all right? So those 3 are kind of to protect your donor. All right, how many of you guys have done this donor questionnaire? All right, so the majority of you guys have, okay. The thing with the donor questionnaire is you're taking your donor's word at these questions. Are they a needle user? Do you think most needle users are going to tell you that they're a needle user? No, and so that's another reason we follow up with our infectious disease testing, all right? But keep in mind, and with nucleic acid testing and RNA testing now, that window has been decreased. So usually maybe they did drugs yesterday, so they've been exposed, right? And so I think the smallest window now is 7 days. So as long as they haven't been exposed within, within that 7-day window, we should be able to detect it, all right? All right, so questions to protect your donor. Again, if your recipient is under the influence of alcohol or drugs, that's a permanent deferral. If your patient has had surgery, you want to make sure, number one, if they had received blood, so if they've had a transfusion, that's a 12-month deferral. If they've had some type of dental work, maybe they had a tooth extracted or anything, that would, like a minor procedure, that would be a 72-hour delay. So most people who have a tooth extraction are probably not going to go the next day and try to donate blood. So as long as it's been 72 hours from that, you're good. But if they've had a procedure without transfusion, as soon as they have clearance from their doctor and daily activities has resumed, they're good to donate, all right? If they have received a transfusion, that's what the concern is. It needs to be 12 months, all right? Heart disease, cancer, bleeding disorders, other chronic diseases. Again, these questions and deferrals help to protect the donor, all right? So if you think about bleeding disorders such as von Willebrand's disease, what else could it be? Hemophilia A or B. These guys don't need to donate, all right? They need to keep their own blood, okay? They're probably receiving transfusions themselves, actually. or for hemophilia patients, they're receiving a recombinant factor VIII, right? On any type of prescriptive drugs. So if it's antibiotics, that could indicate your patient is sick. And then there are some drugs, and this is from the FDA. You guys don't have to memorize all these deferrals, but if you are ever involved in the donor collection process, you need to be aware of these drugs. So like if your patient, Accutane, so Accutane, a lot of people take that for acne treatment. That's a 1-month deferral. Coumadin and warfarin, if your patient's on Coumadin and warfarin, they need to be off of that for at least 1 week, a total of 7 days. You guys remember from coagulation, if your patient is on Coumadin or warfarin, that is a lifetime, right? They're not going to stop that so they can donate blood, all right? So while they could be off of it for 7 days, usually that is a continuous dosage, all right? So they usually, those patients probably will not donate. And notice this disclaimer down here: do not discontinue medications prescribed or recommended by your physician just so you can donate, all right? It's better to not donate, stay on your medication for your overall health, all right? Just looking on here to see. Oh, notice, all right, so some of you guys as healthcare workers, if you are ever exposed like a needle stick or exposed to hepatitis B, you will go through a prophylactic treatment, right? That is the hepatitis B immunoglobulin. If you are giving that, you are not eligible to donate for 12 months, right? That's 1 year. That is different from the hepatitis B vaccination series, the 3-shot series. If you had just recently finished your hepatitis B series, that's only a 28-day deferral, all right? So this is after exposure right here. Hepatitis exposure, all right? So that's a 12-month deferral versus the vaccination is only 28 days. And we're gonna talk about that. It has to do with how the vaccine is manufactured, right? Was it a live virus that was used, okay? And notice here, growth hormones derived from human pituitary glands, you never will be able to donate again because that's the risk for the anything derived from the central nervous system, pituitary tissue, that's a permanent deferral. Right? There's some language you guys need to, that I keep saying that you guys need to be aware of, and I don't think it's included in the presentation. Temporary deferral means that you are deferred for today. Recommend to come back next week and try again. Let's say if you have a temperature or your blood pressure might be a little increased, your pulse was a little rapid, those are temporary deferrals. You can come back another time and try, or maybe your hemoglobin is low, right? That's a temporary deferral. The other one is indefinite referral. So these guidelines are always changing as infectious disease testing improves. We saw that a lot when we moved from, we incorporated the hepatitis B surface antigen and the core antibody, all of that we're going to talk about in a future lecture. So indefinite means that you are deferred until changes are implemented into their donor requirements, all right? So a lot of people ask, what's the difference between an indefinite deferral and a permanent deferral? Indefinite means, according to the donor requirements right now, you are not eligible to donate. However, if there are any changes, then we could reevaluate, all right? Permanent means that either you have tested positive for HIV in the past, you're leading a lifestyle that puts you at a high risk for infectious disease, and that is a permanent deferral. You will never be able to defer from this point on, okay? Most of the time, indefinite deferrals, they're probably not going to go back into the donor pool, just because now all of our infectious disease testing is pretty sensitive and specific. All right, there's a question on there, unexpected weight loss over 10 pounds. Any of you guys ever gone to the physician? They ask you this question all the time. Have you had any unexpected weight loss? That's just indicative of some underlying condition. If you are actively losing weight when you're not trying to. could indicate some type of serious illness. Again, pregnancy, we don't want to take from our pregnant females. We want to defer them until 6 weeks after delivery, unless maybe the fetus is in some type of distress or there's some other condition going on and mom wants to donate for her fetus. I would say that would have to be a highly severe case in order for that to happen. I don't know if you'll ever see that. So questions to protect the recipient, all right? So we've gone through those questions. Any questions regarding possible exposure or diseases that could be transmitted through the blood, those are to protect the recipient, all right? We don't want our recipients to receive the blood donation in an event to save their life and then have an adverse effect by being transmitted an infectious disease, okay? So those questions are to protect the recipient. And again, these questions are approved by the FDA, all right, and then the AABB, which is the American Association of Blood Banks, provides that questionnaire to all donor facilities, all right? So if you guys don't know already, blood bank is the one department of the lab that's highly regulated. It'll be CAP, of course, definitely FDA regulated. And AABB, it's a voluntary, but most blood banks are going to follow the AAB standards as well. All right, so blood bank is really more highly regulated than any other lab, department of the lab. So the FDA and AABB, they are constantly working to update the questions. So the questions reflect our infectious disease testing. Okay. And just to give you an example of how that would come into play, where's this question? Male donors had sexual contact with another male, and then female donors had sexual contact with the male who had sexual contact with another male in the past 12 months. If your donor answered yes to either of those questions, it used to be a permanent deferral. As of May of 2016, FDA recommended that that could be a 12-month deferral. So those are some changes that can occur. And that would be an example of where it would be an indefinite referral versus a permanent deferral. Does that make sense? So these are always kind of changing, especially now as we're starting to see more of this occur. Because what does that do? Our donor pool is already way decreased. And then so if we defer some of our donors, then our donor pool goes even more decreased. Okay. There's another one that had a recent change. Can't think of it off the top of my head right now. All right, so here's some of the vaccinations that can cause a deferral. And you have to think about how the vaccinations are acquired. If like a lessened virus or bacteria is used to derive the vaccination, we don't want to pass that on to the recipient. So there is a deferral time for that. So if any of you guys receive your MMR vaccination, measles, mumps, and rubella, rubella is the German measles. Your measles and mumps is a 2 weeks deferral, but because rubella is in there, it will give you a 4-week deferral. So you'll need to wait until a month after you get your MMR shot. Polio, typhoid, and yellow fever, those are all 2 weeks. And again, if you're giving your hepatitis B vaccine, it's 28 days. 6 weeks following pregnancy, that's after delivery. Again, tattoos, or now there's a huge movement, permanent makeup. Some females are getting eyeliners, lipstick on. If you have that done, that's a 12-month deferral as well because needles are used. There's a disclaimer on it that says, unless applied by a state-regulated facility, most donor collection facilities aren't going to ask for that state-regulated. If you had that done, they're just going to defer you just to be safe. Mucous membrane or skin penetration, so that's your needle stick or splash into your eye. All right, that's a 12-month deferral. Sexual contact with an individual, high risk of HIV, incarceration in a corrected entity for greater than 72 hours, 12 months. Syphilis, 12 months. If you've been transfused blood components or organs, 12 months. And if you've had the rabies vaccination following an animal bite, that's 12-month deferral. Okay. Some other ones, again, major dental work, 72 hours. So if you have a tooth extracted, wait 72 hours before. If you have symptoms of cold or flu, make sure you wait 7 days. All right, so if you still have the cold and flu and you have a fever, make sure that you're fever-free for 7 days. Good rule of thumb. Again, rabies, 12 months. Measles, mumps, polio, yellow fever, 2 weeks, and then that German fever, German measles is 4 weeks. Yes, ma'am.
So I came on Friday and they gave me a sheet that said if you start feeling flu-like symptoms, call this number like within the next 72 hours, start feeling sick. That just during like flu season?
Well, and that might be too with the recent coronavirus being around now too. I would not be surprised if maybe coronavirus is not implemented into our infectious disease testing as well. And so that's probably why they gave you that. And so what happens is, let's say, and that could be not only for like common viruses, but also like hepatitis B or C. If you have previously donated and then let's say 10 weeks later you come back to donate and you test positive at that point, they're going to do what they call a look back. So every unit that you have ever donated, they keep track of what date it was donated, your previous infectious disease testing, who it went to, who were the recipients. And so in that look back, they have to contact every recipient. All right. So if you guys are ever involved in a blood donor collection quality assurance and performing audits and keeping up record control, it's really huge in the donor facility. So you guys actually might be involved on that side of it. One-year deferrals, hepatitis or HIV exposure, again, goes along with those needle sticks, splash to the eyes, tattoos, ear piercings, blood transfusions, those are all 12 months. And then syphilis and gonorrhea, 12 months as well. And the reason for that 12 months is we just want to make sure that your immune system is not going to build antibodies to the potential viruses. HIV, hepatitis C, hepatitis B, okay? Those are the main ones that we are concerned with, bloodborne pathogens, right? There's some other hepatitis you guys probably talked about in immunology, A and E, those are fecal oral. And so usually while they cause infections, usually they're not a concern for blood transmissions. Malaria deferrals, all right? So if you have traveled to an area that is endemic for malaria, you have a 1-year deferral from the date of your travel, right? So from the date of your return, okay? If you have lived in an area that is endemic for malaria, that is actually a 3-year deferral, all right? All right, permanent deferrals, all right? This means that your patients will be deferred forever, okay? If they've ever had a positive test for hepatitis, if they've had hepatitis past the age of 11. So it's theoretically, if you have had hepatitis prior to the age of 11, it's usually probably due to hepatitis A, all right? And so if you had hepatitis B or C, you've been diagnosed past the age of 11. This rule was actually implemented before the sensitivity of our infectious disease testing, before we were doing nucleic acid testing and DNA testing for the hepatitis B antibodies. Oh, let's see. So permanent deferral, male to male. The FDA has recommended that it be 12 months. It is up to the donation facility to make that determination. So they will have it set in their SOP. So if you've ever had positive tests for HIV, or you've had symptoms of HIV, such as night sweat, swollen glands, fever of unknown origin, if you're a known drug user, or you're involved in man-to-man sexual contact, or if you're involved in sexual workers such as prostitution. Okay. If you've ever had babesiosa, trypanosoma, or Chagas, those are all bloodborne parasites. That is a permanent deferral. And then again, if you've received human pituitary-derived growth hormones because of mad cow disease. I took this table, it just kind of summarizes what we talked about, all the conditions for indefinite or permanent deferral. Here's some accepted medications, blood pressure medications that I mentioned earlier. If your patient's on blood pressure medications, that's acceptable. Oral contraceptives, of course, are acceptable. However, there are some oral contraceptives that can cause your plasma to be green. I've actually seen that. I've had a unit of plasma be like bright green before, probably due to their medication they were on. Weight reduction drugs, vitamins, tetracyclines, and other antibiotics taken for acne. Just be careful with acne. You want to make sure that your patient's not on Accutane, which is a 30-day deferral, right? And again, if your patient's on antibiotics, it's probably a good idea to defer them until their antibiotics are completed. It's not because it's harmful to the recipient, just because they are currently fighting an infection, all right? There's one on here. Here's another list of medication deferrals. This Tegason, Soratane, those can cause birth defects. So we would not want them to be transfused to a pregnant female. Notice here's your aspirin, all right? So if your patient's on aspirin or aspirin-containing drug, they need to be off of that aspirin for at least 48 hours, okay? Now, if we were to use their platelets, now we can use their blood products, we can use their red cells, but we don't want to use their platelets if they're on aspirin because their platelets are inactive, right? There's no use to the recipient. It will do no good. I think that's all I wanted to comment on that one. All right, so if any of you guys have ever donated before, you know that you have to give informed consent. All right, you have to let the donor facility know that you're aware of the side effects, you are aware that your blood is going to be infectious disease testing, and then that you give your consent to go forward with the collection process. So again, those educational materials will include risk of the procedure, some side effects that we're about to talk about, signs and symptoms associated with HIV or AIDS, and that you still have, after the collection process, you still have the ability to disclose that you don't want your unit to be used for transfusion, okay? Now, why would you go through the process and then decide that you don't want your unit to be put into the donor pool? I don't know, but as a donor, you have the right to say, you know what, don't use my unit, all right? You have that right. It's very important that the donors are aware of what test is going to be performed on that unit, all right? Hepatitis B, hepatitis C, HIV, Zika, all right, all of that is going to be tested on that unit. And if they test positive, the blood donor facility is going to notify them, all right? So they will be notified. It is, but doing a donor is not a method for free testing. That's actually a disclaimer somewhere, so. Right, so for the collection, we're going to use an aseptic sterile technique. Usually it's going to have a 2 antiseptics. It's going to use a cleanser to get rid of like skin flora and bacteria. And then they're going to use iodine. So if any of you guys have donated, you know it puts that orange coloration on your skin. All right, so that's the iodine. If you have a donor that is allergic to iodine, you can use chloroquine and then 70% isopropyl alcohol. Right, so you must use an FDA approved container. We want to maintain aseptic technique. We don't want our donor unit, our parent unit to be contaminated, because then every product gets contaminated. Proper amount of anticoagulant, like we talked about, and the person who does your donor questionnaire, your physical examination, is probably not the same person that's going to do the actual collection, right? So you'll probably have a phlebotomist performing the actual collection process. So patient ID is very important, right? So the questionnaire person will check your ID, and then also the phlebotomist should also confirm your ID as well, all right? And blood is going to be drawn from the large vein, so we usually use the anticubital area. Again, this is a 16 gauge needle, so it's very large. We want to make sure that we have a very good vein that allows very good established blood flow, all right? And then here's your 2 scrub solutions that's used. Sometimes you might even have the phlebotomist put a blood pressure cuff on, usually about 14 to 60 millimeters of mercury, just to allow extenuation of that vein. All right. And then again, it is quite a bit larger needle. If any of you guys have donated, it's a 16 gauge. All right. And that's just because we're collecting quite a bit of blood, about 450 to 500 mils. We need good established blood flow. We don't want any hemolysis. We don't want any clotting. All right. So that's why that needle is so large. But you guys, these phlebotomists that work at the donor centers are very good. They do this every day, all day long. Usually, they don't have any problems. I'm getting some faces, so maybe you've had a traumatic experience, but usually they're pretty good. Some people might develop a hematoma. That's one of the side adverse effects. That could be because adequate pressure wasn't applied after. So make sure you apply pressure at the venipuncture site afterwards. It's very important we use that iodine to clean the area. It's very important that you, if you're ever involved in the donor collection process, that you do not touch that site, all right? So you need to find your vein before you cleanse the site, all right? So once you cleanse that site, you cannot touch it again, all right? We do not need the risk for contamination, because this, if it's contaminated, guess what? You could pass it on to the recipient. It could be, because there are some organisms that can survive at 4 degrees at refrigeration. We're going to talk about that in a future lecture. And that could cause a bacterial infection, could cause your recipient to be septic. All right. So we maintain that aseptic technique throughout the collection process. And then also, if any of you guys have ever donated blood before, you probably noticed this type of scale down here. Sometimes the parent unit will be sitting on this scale. Let's them know how much blood is being collected. Again, we don't want to pull off more than that 525 mil max, and so they'll monitor that scale. And your donation time usually takes about 8 to 10 minutes, maybe 12 minutes. If it takes longer than that, sometimes it might be suggested that platelets and plasma not be used, again, because some of the coagulation factors might be initiated. All right. And so it is suggested that the first 8 to 10, maybe 15 mils of blood is not used into the parent unit. So oftentimes, if you guys donate, what you'll see, they have what they call a diversion pack. This is going to be about the first 10 to 20 mils of blood, just because you're going to have some tissue contamination that's going to come out in the initial blood. It will go in this pack. They can use this to pull off the blood for infectious disease testing from this, but it should not go into your donor unit. All right. So what's going to happen is in the very beginning stages, once blood flow is established, the first 10 to 20 mils will go into your diversion pack. Then they will close off this. It usually has like a roller lock. I don't know if any of you guys have ever seen that before. They can stop flow here and then open up flow into this one, and it will go directly into your donor unit. And then notice this one is attached to almost like a balance, and so that is how they're measuring the weight in the unit here. And notice they have a little hub right here. They can actually, after the donor process, they could put their vacutainers onto this hub and collect their samples for infectious disease testing, right? If they didn't pull from the diversion pack. So they could pull blood from the diversion pack for the infectious disease testing. Does that make sense to anybody? Everybody? Okay. Notice also, so here's your parent bag. Notice here that you actually have, and I call this the parent bag, you actually have some separate bags as well. And we're going to talk about what the use of those separate bags are for. Remember, I said that whole blood is now subdivided into separate components. These bags are how we separate the components. So usually when you go to donate, you're going to have your parent bag, you have all these extra bags, you'll have the vacutainer tubes for infectious disease testing, and then it's all attached to the tubing that has the needle on it as well. Okay. So this is a closed system maintaining our aseptic technique. Okay.
I know with our vacutainers, we've got the vacuum itself drawing out
Mm-hmm.
blood. Is there any sort of equivalent here when we use it?
Yeah, so you guys remember when you do the phlebotomy procedure, you have that hub. So that's attached to either the butterfly or the straight needle. This is the same thing. So this is a hub here. I don't know if you can see it, but there's like a little needle on the inside there. This is just like the hub used for phlebotomy.
But I get that. What I'm more or less talking about is for the bag itself, the donor bag.
Oh, no, it does not have a vacuum.
So it's really just.
It does how they use the scales.
Pressure coming through
Yeah.
the system.
Yeah.
Yeah.
All right, so once you get your approximately 450 mils, you've collected your specimens for infectious disease testing, you can remove the needle from your patient's arm. It's always a good idea, once that needle is removed, have your patient apply significant amount of pressure to that site because it was a fairly large needle. All right, so make sure you apply adequate pressure there. Have your donor remain seated for a while, ask how they're feeling. The most common side effect from donating is lightheadedness, dizzy, nauseous, maybe they start sweating, and those are just vasovagal normal reactions, all right? So then if that happens, just give them something to drink, some water, some Sprite, maybe something to eat, all right, to calm those symptoms down. And then make sure that you tell your donors to stay hydrated, usually more so than normal, all right, for the next 4 hours following that donation. And it's a good rule of thumb is that they don't drink any alcohol, all right? So they've just donated about 500 mils. Alcohol will dehydrate you, so that could make symptoms of the blood that was lost, it could heighten those, okay? So it's a very good idea not to drink alcohol for at least 4 hours. That's what documents say. And then smoking kind of has the same thing. You guys remember we talked about what dehydration looks in for your plasma. Smoking can do the same thing. It can also dehydrate you as well. So avoid smoking for 30 minutes. It's also a good rule of thumb if you have those donors that are involved in heavy lifting at work, maybe they should avoid heavy lifting for at least 30 minutes, okay? And then you want to thank the donor. We want them to feel comfortable. We want them to have a good experience, so they will come back, all right? And then again, after that procedure, they do have the chance to still say that they don't want their unit used, all right, for whatever reason. All right. And so this is the confidentiality that's going to be given to them after the procedure, just to let them know we can use it, so your blood will be given to another individual, or we should not use your blood, all right? If at this point you've collected the unit and then that donor says, oh, I don't want my blood to be used, we will destroy that unit, okay? All right, so some adverse donor requirements. Again, vasovagal is the most common. Lightheadedness, maybe your donor passes out, okay? Pale skin, sweating, clammy skin. Again, usually that's caused by the sight of blood, all right? So oftentimes, if I'm involved in the phlebotomy process, I've never done donor collection before, but sometimes you could tell your patient to look away, and that will help them as well. You can also talk to them, get their mind off of the process. You can do that. But usually the sight of the needle or the sight of the blood, that's what's going to cause their anxiety, their vasovagal symptoms. And then hematoma is probably the most common side effect of donating blood. All right, and that, again, try to apply pressure after the procedure. It is possible that taking off blood could cause your patient to go into cardiac difficulties, especially if they were not open in the, if they have any type of pre-diagnosed cardiac disorder. Again, this is very rare, all right? But if that does happen, all of the phlebotomists need to be able to do CPR. And then again, here's your tingling of the lips during the apheresis due to that citrate that we talked about at the beginning of the lecture. And again, they will give them Tums to help with that. If your donor has one of these adverse reactions while in your presence, you will document these adverse reactions to let the collection facility know for future, right? So maybe your patient fainted on you, you definitely want to keep record of that. Okay. And then here's some adverse donor reactions with appropriate treatment. If for some reason during the phlebotomy process, your patient develops weakness, sweating, they do pass out, nausea or vomiting, definitely want to stop the process, right? We don't want to take off any more blood. We want to keep our donor's health, you know, in mind. Convulsions or cardiac difficulties. Those are the most serious adverse reactions during the phlebotomy process, and again, very rare. Okay, so processing the donor unit. Every donor will have an ABO-RH performed if the donor is negative at initial spin during the RH testing. Week D testing must be performed, and you guys all know why, because if a week D positive unit is labeled as RH negative and given to an RH negative recipient, but your donor actually has some D antigen. Remember, the D is very antigenic, all right? So if your donor has some D antigen, is transfused into a RH negative patient, that patient could have a transfusion reaction and most oftentimes will be sensitized, meaning that they're going to build anti-D, all right, which would affect future transfusions, all right? We're also going to do a IAT. We do an IAT on our donors, and this comes into play if you think about the plasma. So if your donor has a positive IAT, meaning they have an unexpected allo antibody in their plasma, we don't want that plasma to go to a donor who has the antigen on their red cells, correct? All right, that could cause a transfusion reaction as well. So if a patient has a positive IAT, what the donor facility is going to do is probably not use their plasma. All right, we can still use their red cells, we just won't use their plasma. All right. And then here's your infectious disease testing. We're going to go in depth on all of these in a future lecture, but the FDA mandates that the hepatitis B surface antigen as well as the core antibody be included. And then you have your HIV-1 and HIV-2 antibodies included, as well as antibodies to hepatitis C. And we'll talk about all of those, whether it's nucleic acid, DNA, and what the window is now. We'll go into depth in that in a future lecture. Syphilis, and you also have nucleic acid for HIV, West Nile virus, and the newest one added is Zika, all right? Used to be, most of these infectious diseases testing were just to identify the antibodies, so it was all like serological testing. Now with nucleic acid and DNA and RNA, most of these are done on the molecular level, all of these, and so that has really decreased our window Again, I think 7 days is the smallest window that we have. All right, so preparation of the unit. So after you have your unit, remember I talked about that mother unit, all right? So you have, that's whole blood. It has red cells, has plasma, has your white cells, and your platelets. We're actually gonna stick that unit into a centrifuge, and we're going to centrifuge it, separate the red cells, and that's a soft centrifuge, all right? We're gonna separate the red cells from plasma-rich, or platelet-rich plasma, okay? And what that looks like, so here's your mother unit with all of the components. After that soft spin, you're going to be left with platelet-rich plasma, all right? Then we can express the platelet-rich plasma off into one of the other bags. Remember that I mentioned was attached to the mother bag, all right? You can express this off. Then we can hard spin that bag, all right? So here's our platelet-rich plasma. Notice here we're left with our, this is what we call packed red cells, okay? So it's nothing but red cells. Very minute amount of plasma remains in here, but not enough to cause any harm or anything like that, okay? So here's your platelet-rich plasma. Then we can do a hard centrifuge, okay? We'll separate the platelets at the bottom, leaving the plasma on the top. So then we can express off the plasma. So then we're left with platelets and then plasma here, all right? So this is how all of our different products are derived. This is after hard centrifuge. Notice you have your platelets here, and then you have your plasma here, all right? And we're going to talk about anticoagulants. Remember, anticoagulants are already in the bag, okay? At this point, when we have, depending on which anticoagulant you use, will determine how long your shelf life is for the red cells, all right? So with a CPDA normal anticoagulant, we can extend the shelf life of our red cells by adding an additive, all right? So at this point, after your plasma and platelets have been pulled off, we could add an additive to here to make the shelf life longer. Okay. I took this image from your textbook. I thought it kind of further explains. So notice here's your whole blood, this is your parent unit, and then here's your other bags, all right? Your component bags. Notice here's Adsol 1, which is a preservative. It's already in this bag. So what you can do after a soft centrifuge, notice that here's your red cells, here's your platelet-rich plasma. The platelet-rich plasma is expressed off into another bag, and then your, they actually have Adsol 1, which is your preservative, in another bag. They will add it to your packed red cells, right, to extend the life shelf. Then you're going to take your platelet-rich plasma, spin it down, hard centrifuge, you're left with platelets. Then you can express off the plasma. You could actually take that one step further. If you were to rapid freeze the FFP, you would have, and then centrifuge it down, you would have like this white, what's the right word? Substance. That is cryo. You guys remember we talked about cryo? So after you freeze it and then thaw it out, you're left with cryo. And then cryo could be put into another container. Remember what cryo contains? Von Willebrand's factors 8 and 13. All right, so it's a concentrated factor for von Willebrand's 8 and 13. Okay. So a unit of whole blood has the potential for 5 units, 5 separate components. You have red cells, you have platelets, you have plasma, you have cryo, and you could even harvest the granulocytes out of that, all right? So you could actually end up saving 5 separate lives. So that's why it's very important that you guys donate. Do your civic duty, save lives. I typically can't donate very much because my hemoglobin is not ever greater than 12 and a half. So. And so I mentioned expressing off, and this is not a very scientific process, but if you guys could see in this picture, I took it from your textbook. Notice this unit has been centrifuged. Might be kind of hard to tell. But see, here's your layer of red cells, and then your layer of plasma on top. So this unit is called, this apparatus is called an expressor. So this folds back, you place the unit in there, and then you can apply pressure. And your once you open the port up, the plasma will start flowing out, and that's how you can get it into one of the other bags. Okay, and so as soon as you see red cells up here, then you can stop. And then we have what we call a, I can't think of that name. It's a sterile sealer. And so it uses heat and a sterile copper plate that will fuse the tubing. So then you can separate the parent bag from all of the other bags. Maintaining aseptic technique, keeping that closed system. When you guys will actually get to go to blood bank, and I will show you the sterile docker that I was talking about. I'll show you that. Now this is done, so you guys, unless I will plan for you guys during your internships to go to Arkansas Blood Institute, so you guys can see the collection process, see the product preparation process. Your donor facilities will do this. All right, so this, if you're working in a clinical blood bank, unless you're attached to a donor facility, you guys will probably not be involved on this side of it, right? Unless you work at the donor facility. All right, so processing the donor unit, what happens next? So now you have all your individual components. Labeling, again, very important in blood bank, all right? So on each unit, and this is what a unit looks like if you guys haven't ever seen it. Notice on the unit, you'll have your product, all right? So this is red blood cells. Has AS1, which is one of our additives, all right? So that's what's in there. This product is actually leukocyte reduced, all right? So that means the white cells, it's been filtered. The white cells have been filtered out, and it's also irradiated, indicated by this tag right here. And we'll talk about irradiation in the next lecture. Your donor's type, so this unit is B negative. Notice that it's also barcoded. So here's your unit number. Embedded in that barcode, you have your donor collection facility, you have the unit number and the expiration date. All right, so you can, most all blood banks are computerized now. So when you bring in the inventory, you can scan all your labels. It'll log in your collection facility, the type, the expiration date. Okay. So this has reduced a lot of human error by scanning barcodes. So we talked about the type of anticoagulant, the volume of the unit. You guys might not be able to see it on there, but it's listed right there to tell you how many mils of red cells are in that bag. And then how many mils of anticoagulant. The receiving hospital must confirm the ABO-RH of these donor units. So oftentimes when you receive a shipment from your donor facility, you will pull those donor units out, log them into your inventory, and then you are going to repeat the ABO-RH testing on each of those units to confirm it. All right. Notice there's also a special pink sticker up here. I don't know if you guys can see it. It says E positive, C negative. This means this unit has had some antigen typing done on it. And this donor is big E positive, big C negative. So this unit could be cross-matched for a patient that has anti-C, all right? Sometimes your donor facilities will antigen type for you, and if they do, they'll have a tag that's attached to the unit, and all of the antigens that unit is negative for will be listed. You'll see that a lot on sickle cell patients. They will require units like that if you order directly from the donor facility. And notice in here, you can barely tell it, and I'll show you guys one in lab. Notice that on this tubing, it has all of these segments on here, and each segment has a unique number that is attached to this unit. You can do cross-matching on these segments. You can do antigen typing on these segments, and we will keep those segments for 7 days post-transfusion to make sure that there is not a transfusion reaction. Right? In the event your patient has a transfusion reaction, we will pull these segments and repeat are cross-matching. We can perform antigen typing on it if needed, right? So these segments, that's how we access blood in the unit without opening the unit, right? Once you access the port, like this one has, this port has been accessed, that changes your expiration date to 24 hours. Okay, so once you open that system, your expiration date is 24 hours. But you guys will need to know that. We'll talk about that a little bit later too. And that's just because of the risk of bacterial contamination once that port is accessed. All right, so our anticoagulants and preservatives. So the anticoagulants are designed, number one, we keep our blood from clotting, and then we can also add some preservatives to extend the shelf life of our red cells. When we extend the shelf life of our red cells, we want at least 75% of the red cells to be viable to last at least 24 hours in our recipient. All right, most of them are going to last longer than that, but they need to last 24 hours or greater once transfused. There's some chemical things that happen during the storage of red cells. All right, as you can imagine, some cells will start to break down. Potassium is going to be released. So as those cells on the storage shelf, potassium will be increased, lactic acid will be increased, and the amount of 2,3-BPG, you guys remember talking about that in hematology. Once 2,3-BPG is incorporated into the cell, it forms like those bridges in the hemoglobin molecule, allowing for oxygen release. Remember, without 2,3-PG, it does not release the oxygen. As cells store on the shelf, the amount of 2,3-BPG decreases. All right, so, but that's okay. What happens is, once it's transfused into the patient, that 2,3-BPG is revived and then can allow for adequate oxygen delivery. Okay, so that's kind of the reasoning behind we add some of our anticoagulants and our preservatives, and we're going to talk about that. All right, so glucose, ATP, and the pH, they all decrease as our red cells are stored. Lactic acid and potassium increase. And then again, like I mentioned, the 2,3-DPG, 2,3-BPG, those are used interchangeable. DPG or BPG is important in the release of oxygen. So if DPG decreases, the likelihood of oxygen being released also decreases. All right, that's a concern. If we're transfusing red cells into the recipient, we need oxygen carrying capabilities. That's the #1 reason for red cells to be transfused. Okay. I took this from your textbook. It kind of lets you know what happens as the red cells are being stored. Again, some cells are going to break down, so you'll have increased plasma hemoglobin, increased plasma potassium, decrease in autoviable cells, your plasma pH, and your ATP and D3PG are going to decrease. All right, that's just a normal biochemical mechanism as cells are stored at 4 degrees. Right, so it's a known, all of our current anticoagulants can only maintain that 2,3-DPG status for about 1 week. All right, so the longer the red cells set on the shelf, the lower that D3-DPG gets. Again, like I mentioned, however, once they're transfused, the cells can regenerate that ATP based on what we have used as anticoagulant and preservative. Okay, so that's one of the reasons behind we add Adsol as a preservative, because it helps those cells regenerate ATP, therefore can produce 2,3-BPG. Okay. All right, so one of our anticoagulants is citrate phosphose dextrose, termed CPD, or citrate phosphate 2 dextrose, so CPD or CP2D. It has a less acidic, all right, so it's going to maintain 2,3-BPG. It has dextrose, which is going to play a role in providing nutrients for the cell to regenerate ATP. And then phosphate, again, is just the buffer to maintain the pH. If CPD or CP2D is used as an anticoagulant, your shelf life is 21 days. You guys need to know that. CPD, CP2D, 21 days. Okay, that is a really good board of certification exam question. And the storage temperature. Blood bank is really big on storage temperatures. So your red cells are stored at refrigeration. Refrigeration must be 1 to 6 degrees. Okay, I say 4 degrees. That's usually the mid-range. Anything lower than that can cause cell hemolysis. Anything higher than that, you put your unit at a risk for bacterial contamination because bacteria. These red cells have the nutrients needed for bacteria. Right? They love this medium. All right, so they can survive. If your temperature gets out of, if your unit gets out of range, increased temperature, we will discard the units because it has been exposed to bacteria. All right, has the potential to harvest bacteria. So that's the temperature concern in blood bank. All right, so then you have another anticoagulant, citrate phosphate dextrose adenine. So it has adenine added, which adds a adenine nucleotide to the pool, which further allows for synthesis of ATP. All right. It extends your shelf life to 35 days. Okay. Because of the addition of adenine. All right, so those are anticoagulants, CPD-A, CPD, and then CPD-2A, right, or CP2D, all right? Those are your regular anticoagulants that are in your mother bag, right? They're already in there. We have some additives that we can add. And we have Adsol 1, Adsol 3, Adsol 5, and there's actually even an Adsol 7 now, right? And so what this has, it has saline, it has adenine, it has glucose, and then it has mannitol, all right? Mannitol is going to help reduce the amount of cell lysis, right, during the storage procedure. Notice that there's really not, it uses saline, so it really doesn't have a buffer. So the 2,3-BPG is a concern. So the decreased 2,3-PBG is still a concern. It has extended. If your units have Adsol added, your shelf life of red cells is 42 days, okay? So CPD, CP2D is 28 days, all right? CPDA is 35 days, and if you add Adsol, 42 days, all right?
Isn't that 21 days?
What did I say?
28.
21 days. If you irradiate, it's 28 days.
Do we need to know that?
Yeah, we'll talk about it a little later. All right, so those expiration times are very important. Okay, your shelf life. I took this table from your textbook as well. It kind of outlines the role of each additive in our anticoagulants and our additives. I want to show you guys something real quick to hit home. All right, so notice here's your mother unit that I mentioned. This already has your CPD anticoagulant in it, all right? Notice a couple steps down. Once your plasma-rich, platelet-rich plasma has been pulled off, in this step, here's your Adsol preservative. After the red cells are in the bag by themselves, the Adsol can be added, all right? So it does have CPDA, but then we're adding Adsol as a further preservative, okay? So I want you guys to understand the difference between the anticoagulant and then the preservative, all right? So that's why Adsol extends your shelf life to 42 days. All right? Does that make sense to everybody? Oops. All right. So we talked a lot in this lecture, talked about our blood donor collection process. We talked about the questionnaires, what questions help protect the donor versus the recipient. And we talked about the component preparation process, the development of packed red cells, plasma, platelets, cryo from the whole blood unit, right? And then we talked about our anticoagulants and our preservatives, okay? You guys, in this section, we're gonna talk about a lot about components. How do we store our plasma? What temperature do we store red cells at? What's the expiration time? Those are very important. And yes, you do have to know those, okay? Not only for this class, but for the Board of Certification. And I'll show you in the next lecture an easy way to remember it all right? All right, anybody have any questions on the donor collection process so far?
Is that normal for them to take it from the side of your arm?
I would say wherever they have the largest vein that will establish good blood flow. So typically, so they went on like the outside.
They went way over there.
I would say so I would say it's more painful for your recipient if you go on the outside or the inside. So typically that middle region, but they're going to go wherever they have access to a really good vein.
So is malaria not a permanent deferral anymore?
So if you've had malaria,
My dad was exposed to malaria back in the 70s or something, and took anti-malarial drugs, and now he's apparently no longer able to get blood for the rest of his life.
yeah, so if you've had malaria, babesiosa, Chagas,
I
trypanosoma.
don't think he actually had malaria, but he was exposed to malaria in Africa.
Oh, so usually if you travel to an endemic area, usually it's a 1-year deferral. If you lived in an area, was he in the military?
Yeah. I don't think he was stationed in Africa. He was stationed in Germany, though. That might have been.
But he received, even if he received anti-malarial drugs.
I'll ask him more detail.
Yeah, ask him.
But I remember the last time I gave a blood test, if I had been to Africa in like the 70s, between 76 and 77. But that was when I was like 19. I was born in 94.
Yeah.
It's literally impossible to do that.
Right.
Cherica says Adsol, it's a preservative.